Director of the AIDS Law Project of Pennsylvania, the nation's only independent public interest law firm dedicated exclusively to people living with HIV. The ABA HIV/AIDS Impact Project, section of Civil Rights and Social Justice, and Center for Human Rights is excited to be presenting this timely panel entitled Managing Privacy and Compliance with Public Health Guidelines During the Pandemic. This panel is the second in a series of webinars surrounding HIV legal issues. The HIV/AIDS Impact Project is actively planning additional programming on a variety of issues, so please visit americanbar.org/CRSJ for updates on these programs. During today's programs, we encourage you to ask questions of our panelists through the Q&A, not the chat function. If you do not see the controls, please ensure your screen is not idle. Depending on the volume of questions, we will try to take them in real time. We will also reserve time at the end of the panel to answer questions. We will be sharing a recording of this program to everyone who is registered so that you can share it widely with your networks. Our panelists today are Daniel Bruner, Senior Director of Policy, Whitman-Walker Health, Catherine Hanssens, Executive Director and Founder, the Center for HIV Law and Policy, and Amy Killelea, Senior Director, Health Systems and Policy of NASTAD, which is the National Association of State and Territory AIDS Directors. So, according to the CDC, as of noon yesterday, the United States has 6.5 million COVID cases, more than 195,000 deaths, and 250,000 new cases just since last week. So doesn't this mean we need to do everything we can to stop the spread? We wear our masks, we wash our hands, we stay away from large crowds. But does it also mean that medical privacy is less important? After all, celebrities, other public figures are heroically and patriotically coming forward to inform us they have COVID and that they are surviving. Shouldn't we all be willing to give a full report of where we were, with whom we were, and to whom we saw? Shouldn't we be willing to allow full access to whoever is interested in this information? In HIV, we each, mostly, get to make our own decisions on our risk tolerance. But with COVID, our ability to stay absolutely safe is dramatically reduced. Doesn't this difference in the risk of transmission warrant a relaxing of medical privacy? And we know that with HIV, although that we say there's no shame in having a virus, that people living with HIV suffer from stigma, discrimination, criminalization, and even violence once their HIV status is disclosed without permission. But if we aren't yet seeing that with COVID, do we need to closely guard COVID-related information? If we surrender our privacy now, will we be able to retrieve it once people with COVID are victimized? Will we ever be able to claim it? We do know for sure that we aren't really protecting people if we expose them to unintended consequences. So where is the balance between protecting the people and protecting the public health? So this afternoon, we'll begin this discussion with a panel of folks who have been thinking about these important questions. So let's start with Amy and the Public Health Data Privacy Regulatory Scheme. Amy.
One second here. All right, can you see my screen? I'm getting a thumbs up, perfect.
Oh, there, yes.
All right, thank you, Rhonda. Good afternoon, everyone, and thanks for the opportunity to be here today. I'm Amy Killelea. I work at NASTAD. We are an association. We represent folks at the state, territorial, and a handful of local health departments who oversee HIV and hepatitis programs. So I'm going to kick us off with an overview of some of the data privacy issues that are emerging during the COVID-19 crisis and what we can learn about our approach to, just as Ronda said, the balance between public health and privacy. And so let's start with the federal and state sort of statutory scheme that governs public health data. And I've broken this into federal law and state law, color coded in front of you. But I will say at the outset, I am not going to go in detail here. We could have a separate session just on this slide alone. But a few things to point out. One, on the federal side, the most relevant and probably most well-known statute is HIPAA, that governs a large swath of healthcare identifiable data. However, it becomes less relevant in the sort of health department, public health context, both because many health departments or parts of health departments are HIPAA exempt, and because the public health exceptions to HIPAA are gigantic. For our purposes, what I really want to do is sort of zero in on this middle one you see in front of you, state communicable disease statutes. These are really at the heart of safeguards around data held by governmental public health. And I'm going to focus on that. Health data and public health data is held by a lot of different players. I think some of the other panelists will get at some of that. But my focus is going to be on this governmental public health role and what privacy and confidentiality requirements and protections should be in place. So let's sort of zero in on that bucket of state communicable disease statutes. I will say at the outset, as with anything in this country, there is incredible variability across states in communicable disease statutes. They are structured differently, they look differently, they cover different things. This is a like 10,000 foot kind of framework. And we can distill from sort of themes and how these statutes are set up. So, this is where some commonality is. You start with a presumption of confidentiality. And that's usually found in a specific provision or set of provisions in the communicable disease statutes that prohibit data release by the health department without a person's consent. But then we see on the other side of this line, right, exceptions, an array of exceptions, including really broad public health justifications that encompass, operation of surveillance programs, which we'll talk about, exceptions for a response to a public health emergency, exceptions for enforcement of control measures, or in response to a court order or subpoena. And like anything, if you broaden out these exceptions so much, they explode the protection. So I want to get into a bit more detail of this, but this is sort of the framework that we operate in. So with that framework in mind, governing health department data release, I want to walk through. There's a lot going on here, but who doesn't like a picture of surveillance data and how it works? So let's take a closer look of how state health department surveillance systems work in practice and where some of the data release, how it works and where some of the concern areas might be. So if you start on the far left of your screen over there with patient X sort of happily going about her life, and she goes in to her provider, and let's say it's an urgent care center, to get a COVID-19 test. This works the same for HIV as well, I will say. This is sort of a basic rundown of surveillance. So she goes to the urgent care center. The urgent care center, gives the test, it's processed by a lab. The lab has to send that positive test result to the state health department. So that result and its identifiable data with that person gets sent to the state health department. There's no consent for that. Patient X does not consent for the lab to send that information to the health department, but our surveillance system depends on that release, and that is allowable in statute based on the public health exception to confidentiality. Then we have sort of a choose your own adventure set of release authorities that the health department has that are either really expansive or fairly limited. And this is where the variability in state statutes come into play. at the very least, the health department will contact patient X. They will, and the provider will also contact patient X. There's a provider-patient relationship there, like that they're going to give treatment advice, and that will be available to the patient. But the health department will also contact patient X. We'll tell them you've got a communicable disease. If it's COVID-19, we'll talk about transmission sort of mitigation education, and we'll ask about potential close contacts that patient X may have had. And then, there will be a conversation, and different programs are structured differently. But the health department may engage in contact tracing. And so the health department employee or a contracted entity of the health department will call with patient X's sort of permission, and without identifying patient X, will call the close contacts identified by patient X and let them know you have been in close contact with someone who has been diagnosed with COVID-19. Here are the risk mitigation steps that you may want to take. So that's all sort of the initial kind of response to that patient X. Then the health department will send a whole bunch of de-identified data to CDC. CDC, as we know, is tracking COVID-19 as well as other infectious diseases, including HIV. That information, that data is not identified to CDC, but it is a required set of transfers from state and local health departments, usually the state health department, to CDC. And then, often we see health departments providing, and I mentioned this for COVID-19 because I think it's important. We're learning a lot about COVID-19. So there is data flowing to researchers. Again, there are a whole separate set of privacy and confidentiality protections, and those data are, for the most part, with very limited exceptions, de-identified. And I want to end with, and then take a little bit more time talking about, like, this is the meat of the controversy. Health department will sometimes provide identifiable data to law enforcement or first responders. In the COVID-19 sort of case, several states have mandated provisions, have mandated that the health department provide positive cases to first responders as an added protection for first responders. I will say, and some other panelists may address this, many argued that this was not necessary, that first responders should actually follow universal precautions no matter who they're seeing. But nonetheless, many states, or a handful of states, felt that the need to sort of add that. And that was an allowable transfer of data without consent to first responders. In addition to that, many states have laws on the books that actually mandate, in some cases allow, but in many cases mandate, health department release of identifiable data, again, without consent, in response to a subpoena or court order in the course of enforcing public health code violations. And we see this quite a bit, or more than we would like, in the HIV context. So we've brought up law enforcement. I think that's one of the big sort of flashpoints, and I think the right question at the outset of how do you create a dividing line, and where does public health end and law enforcement begin, and what does that line really need to look like, both ethically and in order to have a sound public health response. So, I would argue, and I think this is up for debate, that as we blur the line between public health and law enforcement, we're actually creating a deterrent to sound public health response. NASTAD has supported policies that actually prohibit a health department from releasing data for any law enforcement purposes. So that just firewalls the data that any health department is collecting solely for public health purposes. So it takes the decision sort of out of the health department completely. But when we get into the range of public health interventions that we see for COVID-19, it gets even blurrier. In multiple states, violation of COVID-related public health requirements. So these include things like quarantine orders, a stay-home order, a mask order, sort of business safety, and sort of public gathering requirements. Violations of these can carry monetary fines. They can sometimes even carry jail time, and are actually enforced by the police. And again, I think we'll hear from our other panelists, and I want to raise this, and this should probably go without saying, but mobilizing a law enforcement response, a police response for a public health crisis can really exacerbate systemic racism and over policing of certain communities, and can undermine trust and faith in public health. So, no matter you think enforcement of a mask order is good, and I do, I think everybody should wear masks. I think it matters how we get there. We may actually undermine the ultimate goal, depending on what enforcement looks like. So we're going to move a little bit of a related but separate topic. It is an equally sort of confounding public health privacy issue, and I think raises a lot of new ethical questions for us. We are seeing a new type of kind of technology and data use emerge in the context of COVID-19, and that's an increased use of digital apps. And particularly, I'm going to talk about digital apps used for contact tracing. So as we said in our sort of surveillance schematic, that's sort of exactly what it sounds like. Someone tests positive for COVID-19, and there is a public health effort to identify any of the close contacts that person has had within 14 days. So one app that's gotten a lot of press was created by Apple and Google. And the technology they use is actually, it is not GPS, it's not cell service data, it's Bluetooth. And so they use Bluetooth data to notify individuals when they've been in close proximity to a known COVID-19 case. So I found that fascinating because the particular API isn't tracking or storing location data. It's location agnostic. It is looking at proximity data, and it's able to just capture that using Bluetooth. And so I actually, in furtherance of the cause in this presentation, I downloaded Virginia's version of the app. And so I included screenshots of that below in front of you. And so this is actually, these screenshots are directly from my phone. So this is what it really looks like. And the first on your far left, it's optional. I can opt to download the app. Nobody has told me that I had to. I went to like the app store on my phone, and it was a free app, and I downloaded it. And then there's like a series of questions, and I can opt to receive notifications. I affirmatively press the button, yes, I want to receive notifications if I've been in close contact with someone who has tested positive for COVID-19 in the past 14 days. So you can see that as of yesterday, when I downloaded this app, no exposures have been detected, and that would change if I had been in close contact with someone. If I test positive, I can voluntarily, and again, I affirmatively do this, I can voluntarily disclose the data via the app to the Virginia Department of Health, and they will confirm the diagnosis, because the Virginia Department of Health, when I get diagnosed, will give me a 6-digit PIN. So my personal information is not disclosed via this app. I'm not disclosing it to the Virginia Department of Health, and I'm certainly not disclosing it to any contacts who have been in my orbit over the past 14 days. So some of you might be out there thinking, this is really neat. And some of you might also be terrified.
Sorry,
Yep.
2-minute notice.
Thank you. And so, I think one of the things that's concerning about this is that, the app vendors themselves are falling outside of HIPAA. And we don't have a comprehensive federal electronic health data statute. So right now we're relying on vendors to self-regulate. And to be fair, the privacy policies of Apple and Google for this app aren't bad. But I think, we may not want to leave those decisions to the tech industry. So let me move on. I want to I'm going to go quickly through these next 2 slides. I may ask for like an additional 45 seconds, Ronda, so just know. But so I want to just step back for a minute and walk through some of the ethical and practical considerations of kind of running down this road of sort of access to data to respond to public health. I mean, number one, surveillance data, public health data, is only as good as the underlying testing regime. And this is important. HIV, we have a pretty good, solid underlying testing regime. COVID-19, we do not. I think it's a basically accepted truth by most people that the US testing strategy has been flawed. And now that the testing shortages of the types of tests available, so you've got sort of 2 main tests available. One test is molecular. That's the test where you've got the really unpleasant nasal swab. It takes a little bit of time to be processed by a lab. It's more expensive. It takes a little bit more time to process. It is far less available. We have not been able to ramp up the availability of molecular tests. So then we move on to a rapid antigen test. And I'm going into detail here because I think this is important. States can't get molecular tests, so they're ramping up their use of antigen tests. Antigen tests are great. They're rapid. You only need like a paper, a little piece of paper strip to get your results. You get your results at point of care. They are not as accurate. So to base your sort of public health strategies and to base your public health strategy, you have to really look at what kind of data you have and what you can do with that data. And I think that's been important in the HIV space to interrogate, like, what can you do with this data? What does it tell you? And we have to do that with COVID-19. And I'm going to end with talking through some of the lessons learned very, very quickly, because I think my colleagues are going to talk about this more. I think what I want to I'm just going to go through like two of these. One is that we can stop ourselves, right? We can put state laws in place or regulations in place that actually say, health departments, you cannot release data for law enforcement purposes. And then you've got a firewall, right? And nobody's making a decision. It's not discretion. It's just, you can't do it. And some states have done that with HIV. And I think we could think about that for COVID. Engaging communities impacted. That's been incredibly important for HIV to help talk through, like, what are the changing technologies, the changing science of HIV, and what are the needs for privacy? What does that balance need to look like? And we should absolutely be engaging communities most impacted. And so that I think is a great place to end. I think resources are available on the website, and I am going to turn it back to you, Ronda, I believe.
Thank you, Amy. Thank you for that presentation. It's certainly a brave new world with the Proximity Act. So let's hope that the lessons learned from HIV keep us safe through COVID. Let's hear from Catherine now on keeping police and public health in their lanes.
Thanks, Rhonda, and thanks, Amy. Let me try to get my slides up here. How's that looking?
Looks good.
Excellent, thank you. I think there are several areas that I think blend in with what Amy was talking about that are appropriate to kind of zoom in on. These are the three areas I'm describing here, certainly relate to COVID and privacy issues. They are not the only issues that are relevant. There are plenty more, but these are the ones I'm going to focus on here. And I think just before I start, a couple of comments about Amy's excellent slides and presentation. The laws that we're talking about, and HIPAA in particular, tend to have exceptions for law enforcement that you can drive a truck through. And even though there are laws in the books that allow, and in some cases even mandate, public health data sharing with law enforcement, there are ethical issues and also legal issues that sort of beg the question of why aren't these laws being challenged by public health professionals? My guess is that a number of them would not stand up. But anyway, we're going to start with, if I can find my little arrow, emergency triage protocols. And I'm including this because the concept of privacy obviously includes the more literal understanding of privacy, which is keeping sensitive data about yourself to yourself. It also has to do with bodily autonomy and the ability to make decisions about healthcare and to access that healthcare. And one of the things that we found during the COVID epidemic is that most states do not have or have not had appropriate protocol for triage of who is going to get interventions. And a lot of times ventilators are the issue that come up when there aren't enough to go around. And although most places manage to get over that particular issue, the notion that this is not going to come up again, either with COVID-19 or another deadly coronavirus, is, I think, wishful, magical thinking. Even the places that have adopted them when they were sued by the Office of Civil Rights are generally guidelines and they're not mandatory. So this is an issue that the Center for HIV Law and Policy has been focused on with some other partners here in New York to develop some recommendations on what needs to be in those protocols, because again, as something that many people who have lived with or advocated for policies around HIV know, there is a lot of decisions are informed by either conscious or unconscious bias, and that individuals whose lives are not viewed as valuable as others can often get the short end of the stick. So we need to make sure that there are mandatory guidelines, not just suggestions, that they're based on objective evidence, and that there are guardrails against persistent bias. And I think that's an area that really affects people living with any form of disability, where there are assumptions rather than an individualized assessment about that patient's prognosis. There's often a view that if somebody comes in a wheelchair missing a leg, that they are less worthy of a ventilator than somebody who is completely ambulatory. And those are exactly the kinds of concerns and presumptions about who's worth saving that we need to prevent against. These are just some other points to think about in terms of protocols. There are triage teams. I know you all can read these slides are going to be available on the website, so I'm going to try not to go through and read them all. But some key things I want to highlight in this particular slide is that it really is incredibly unfair, in fact, to impose on healthcare workers the burden of determining if there are 6 patients and 5 ventilators, who's going to get them. And so it's really important to have triage teams and have people who live with disabilities as part of those teams to ensure that reality rather than bias are part of the decision making. One of the things that we're looking here in New York is to, as I'm putting it here, weaponizing the hospital patient bill of rights. Almost every state has it, and it would be a lovely thing if a state bill of rights for patients was as well known as HIPAA, and was also had a private right of enforcement and included provisions that guaranteed that race, gender, sexual orientation, disability would never be a basis of determining access to care. More to the point of the kind of privacy that Amy was talking about is trying to put a limit on contact tracing information specifically related to COVID. And one of the things, and if there are advocates who've been working on this for years, they already know that there has been a huge effort that David Weber, the founder of the AIDS Law Project of Pennsylvania, editorialized about maybe 20 years ago about the need to create a firewall between public health data and non-public health uses. That advocacy has been, at least with the CDC, to have them require that of states in exchange for things like Ryan White Care Act money, have been dismally unsuccessful. So it seems that the place to focus is at the state level. Here in New York, there is a bill that passed through both our Assembly and our Senate and is getting dusty on Governor Cuomo's desk, but would both defines law enforcement quite broadly. One of the things we learned is that there were, in some counties, there sheriff's officers who were actually involved in doing contact tracing around COVID. I don't know that you want somebody with a badge showing up on your front porch to tell you you've been exposed to COVID. And it really does absolutely limit any kind of access with law enforcement beyond, well, period. It's only for public health purposes. So I'm jumping around because I have, as I told Ronda, and she knows so well, I have a terrible concept of time. So I don't run over. Thank you. The third area that I wanted to talk about are more, I guess, proactive, affirmative approaches to the kind of mission drift that Amy was describing, where public health gets involved in law enforcement and law enforcement gets involved in what is really a public health issue. And I think in the HIV field, it has been far from rosy. And an example of, and it's not the only one, but an example of a particularly bad state law is in Missouri, where under their HIV statute, they actually specifically authorize the Department of Health not only to institute criminal charges by filing a complaint with a prosecutor, but they require them, they are told that they shall assist the prosecutor in pursuit of a criminal case against anyone who has exposed another person to HIV. And in the notorious case of Michael Johnson, which some of you may be familiar with, someone from the health department did actually testify to the counseling he supposedly received and how he was told not to have unprotected sex and notify patients. So there we have what seems a clear ethical violation of someone engaged in counseling and health, switching that hat for a police hat and using that kind of information to get somebody convicted of a felony. So I think, we're talking now about staying in your lane. There are a variety of parallel lanes that have to do with public safety. And also, in fairness to prosecutors, I think there is a real issue of a vacuum created by people in state and federal and local public health failing to step forward and claim jurisdiction over the areas that they should be monitoring. So if there's nobody to call but the police, that is often whom people call. However, we, as you can see here in the slide, in May, got together with the Association of Prosecuting Attorneys, the National Association of Criminal Defense Lawyers, the Community-Oriented Correctional Health Services, several programs at UCL School of Law, and with the support of NASTAD, Amy's organization, NLADA, and you can read, those folks are all down there at the bottom, came up with a relatively short document that proposed ways that criminal justice professionals and public health principals can stay in their lane and collaborate in a way that is productive rather than harmful.
Catherine, you're at the 1 minute mark, but because we don't have any questions pending now, you should feel free to wrap it up at your own schedule-ish.
Oh, be careful what you wish for, but thank you. And then, meanwhile, barn door was slamming. Okay, and I think I'm almost finished here. But the goal, I think what I loved about this project, if I can say, is that it really does demonstrate something that we've been embracing at CHLP for a while, which is to not make assumptions about who potential allies can be, and to really reach across into other disciplines to collaborate when folks outside of our particular silos are in fact natural allies, but also are essential to change. So the fact that we could come up with a set of recommendations that included a National Prosecutors Association agreeing that we should not be prosecuting people on the basis of COVID exposures or prosecuting anybody on the basis of disease exposure, I think demonstrates the importance of those kinds of collaborations. These are the 5 specific recommendations. They're fleshed out a bit in our pathways document, but this is where we wound up in terms of consensus, that there really is a need to release individuals from prisons and jails based on set criteria and public health recommendations. And I should point out that that's something that should be happening not only in response to COVID, but in response to sensible public health policies. We are over incarcerating people at a rate that creates public health issues inside and outside of these facilities. And it's something that should be set in motion now. That we really should be taking a look at limiting arrests, any arrests that result in new admissions where the offense, the charged offense, does not require incarceration. And that is probably most people getting arrested. That any kind of violation of the COVID-19 related directive be dealt with through public health departments rather than the criminal legal system. I mean, there are some places where police go around equipped with masks to offer to people. Unfortunately, here in New York, we see police not even wearing masks, which is another issue in itself. We need to do a better job at developing alternatives to incarceration that really take a focus on the mental and public health issues that are sometimes leading to incarceration in the first place, and then have real ongoing solid connections among public health organizations, researchers, criminal justice stakeholders, and advocates, where we're working regularly with people rather than running out when we need them as political arm candy to put onto a statement. And I think I am finished.
Thank you, Catherine. Thank you for those principles that I think get us on this path of the balance between the individual and the public health.
You're welcome.
So now we will turn to Dan for his thoughts on COVID, HIV, and the urgent issues of our time. Dan, you're muted. There you are.
Okay, sorry about that, folks. Every time I think I've learned Zoom, I fall on my face again. So thank you, Catherine and Amy, for those really thoughtful and really helpful presentations. And Rhonda, thank you for setting the stage with some really kind of important questions for us to all keep in mind. I want to take a few steps back and talk kind of about some basic things. And for some reason, I'm having trouble moving my screen.
Well,
here we go. Here we go. Okay, so we've been talking about HIV, and kind of all of us on this panel certainly have worked on HIV issues for many years and still do. And I think they're really important lessons from the HIV pandemic for what we're facing now. But I also think it's important to keep in mind the differences between what we're facing now with COVID and what we're still facing with HIV. COVID is highly transmissible through casual contact and simple physical proximity. It's very different in means or vectors of transmission than HIV is. And something that's closely related to that I believe, Rhonda, you flagged at the outset, is people are just much less able to protect themselves from COVID than from HIV. My ability to remain free from COVID infection depends not only on my behavior, but on the behavior of other people to a much greater extent than for HIV. I think it's important to realize that COVID is devastating not only people's health, but it's devastating the economy. And it's the devastations being wrought on health and on the economy are disproportionately coming down on people of color and low wage workers. And an HIV diagnosis or exposure is stigmatizing even nowadays in ways that a COVID diagnosis or exposure is just not. And so it's interesting to think the restrictions on personal behavior that are needed to protect against COVID are really different from HIV prevention measures. And on the one hand, you can say most COVID related restrictions are much less of an imposition on people's lives than telling people, to remain HIV free, you have to modify your sex life or take a daily medication, namely PrEP. And on the other hand, you might say that COVID related health measures are more restrictive than sort of HIV restrictions or measures to protect against sexually transmitted infections generally. Telling people it's now been 6 months. I need to continue to wear a mask in public, not go to restaurants, avoid large gatherings, stay out of church or synagogue for who knows, maybe another year or something is really a challenge. And the fact that COVID is transmitted through casual contact and physical proximity from a public health perspective make it more important to track people's movements than in the case of HIV. And just to flag that there's a trade-off between scaled up testing, contact tracing, and isolation or quarantine if someone's diagnosed or exposed on the one hand. And if we don't have that, and in most states, we don't have adequate measures at this point, and the alternative is really continuing sweeping shutdowns and other restrictions on the general population, or continuing to oscillate between crackdowns and reopenings and then another crackdown. And this just continues to disproportionately impact lower income people and people of color. But of course, there are important lessons from HIV for COVID, one of which is that an infectious disease pandemic reveals and really exacerbates the health inequities and the social and economic inequities that seems sadly at this point hardwired into the American system. As Amy talked about in particular, public health measures are not going to be effective unless there's public buy-in. And it's really important to reach and engage marginalized communities. And we have to be very careful about the enduring impacts of racism and, as Catherine mentioned, criminal sanctions and reliance on law enforcement is particularly fraught with peril when it comes to racially discriminatory enforcement. And I think we also really ought to think about, and we've thought a lot in HIV about how effective is fear as a public health motivator and what are the limits of fear. I certainly remember in the early days of the HIV epidemic, people were terrified. Certainly gay men were, and a lot of other folks were. And it was, at least in the short run or for some years, a really effective motivator in people using condoms, people refraining from sex, limiting the number of sex partners. But people get tired of that after a while. And I think we're already seeing COVID fatigue and familiarity with COVID beginning to affect people's willingness to continue to um, take or adhere to, the recommended guidelines. I just wanted to flag very quickly because I think it's fascinating. There's a very recent, very thoughtful article, which I have the cites to here, um, that points out that usually in a pandemic or a crisis situation that requires decisive public action, we normally in our legal and political culture are afraid of executive overreach. How is the government going to use COVID as an excuse to ramp up surveillance of all of us, limit our privacy, expand government power? But according to these authors, what we're seeing in the US and Brazil and maybe some other countries is intentional, what they call executive underreach, which is intentional refusal to take the public health actions that are obviously called for, fueled partly by ideology and partly just by a desire to preserve and increase power, cultivate chaos and polarization, and undermine public confidence in science. So we really need to think about the harms of government underreach and not just be thinking in COVID about um, the harms of overreach. And the last thing I just wanted to flag, even though it's not the main subject of this panel, is we really need to be thinking about vaccine policy now. Um, Maybe a safe and effective vaccine will be rolled out by the end of the year, maybe sometime, hopefully early next year. It's highly unlikely uh, to be available to the general public for some time. So how will scarce doses be allocated? Uh, and I was thinking about this when I was listening to Catherine's presentation on the importance of safeguards and non-discriminatory protocols for treatment in emergency situations. This isn't really that different from thinking about how do you allocate hospital beds or ventilators. If you need them, who's going to get a vaccine? Who's not going to get a vaccine? Another important thing from the public health point of view is once we have a lot of vaccine available, are we going to be able to reach the needed levels of uptake in order to get herd immunity? And is there a role for mandates for vaccination against COVID imposed by schools, imposed by employers, imposed by public facilities? And I just wanted to end with the fact that I think there's a definite public health consensus at this point that getting a flu vaccine this fall or getting that very widely, getting very high levels of flu vaccine uptake is much more important this year than it's been in the past. And that's something that a lot of people don't do or don't take that seriously. So I think it's a real public health challenge, and may even raise questions about whether or not there's a role for mandates. So that's it. Thank you.
Thank you, Dan. So we have a question that I want to initially direct to Amy, but certainly the other panelists should feel free to share thoughts. So the question is, how do we ensure that smaller community organizations like colleges balance the testing needs with privacy concerns? And when we talk about smaller populations, that becomes a greater concern, because you can kind of easily identify who the people are in question in a smaller population. So Amy, do you want to start with some thoughts on that?
Yeah, I think it's a really good question, and I'll sort of answer it. It's unique. I'll answer it with my public health hat, and then I've also had the interesting experience of living on a small campus during the pandemic. So I think I've seen firsthand some things that have worked in sort of creating that balance and have not. And I would say, you know, broadly, and then I think all three of us talked about this, you know, creating a creating trust and transparency, I think, is paramount. And it doesn't, that's paramount for big and large communities, but I think for small communities in particular. So I think transparency about privacy protections. So if you've got a testing requirement that goes into effect at a college, and many are, my campus has done required testing of all students and their spouses and their families. My family was tested, and having transparency about why the tests are being conducted and how the information will be shared. That's been really, really important. And I think you know, we talked a lot about the differences in HIV and COVID-19, and there are many. And I think stigma is one. I would say, you know, there are many ways that COVID-19 is not nearly as stigmatized as HIV. But on the flip side of that, I think continuing to have to sort of articulate a broad public health imperative as sort of community response to COVID-19, that if you are diagnosed with COVID-19, that is not a reflection on your personal character or worth. That is just something that happened, and that we as a community need to sort of band together to respond to. And that I think is really important in small communities in particular. And you know, privacy protections and confidentiality, how you structure a testing event, that matters too, and who gets information, and the notices that you get before you get tested of, I'm going to get tested, and this is who is going to get my information, how it will be used. That's I think really, really important for a small or college-based setting.
Thanks. Catherine and Dan, anything you want to add to that question or other final thoughts?
The only thing I would add is that I think it gets, it's the disclosure of your status through either testing or partner notification is less of the issue, because partner notification simply tells you you're exposed. It doesn't necessarily tell you who exposed you. And in fact, with COVID, the possibilities are so numerous that it's far less likely that you'll know who the source patient was. And at least in New York, I mean, nobody's getting immediate results, and pretty much everybody I know is waiting at least 2 weeks to get test results, which of course makes the partner notification thing rather pointless. I think the quarantine thing is a little bit more complicated, because you're being, if somebody is quarantined and therefore not doing one thing or another that they might otherwise do with or without a mask, that does kind of out them. So I think, you know, sort of reinforcing the ideas that Amy was talking about become more important there.
Thank you. I think that may be it for questions. So if anyone has any other comments,
Yeah, I had a couple of things I thought just I wanted to just underscore, I think, one of Catherine's points when she was talking about the importance of keeping law enforcement or the police in their lane and public health folks and activities in a very separate lane is that as uh, as you pointed out, Catherine, in some communities, the police were and probably still all are all there is. So, what do you do if you say that you've got mandates which need to be enforced, or at least people need to be strongly encouraged to not storm into a Walmart and refuse to wear a mask and, intentionally breathe on the poor clerk who's trying to talk to you, not to go to large events that are, crowded and without wearing masks, et cetera, et cetera. Uh, Ideally, we would have legions of trained public health workers to do that work. In a lot of communities, we don't. And so it's not ideal and it's very troubling in a lot of ways, but sort of understandable, at least in the short run, that what do you have to rely on? You've got the police. And so you turn to them. And if we say we can't or shouldn't rely on the police, then who are you going to rely on in a political climate where there just seems to be a complete unwillingness to make the kind of investments that we really need to make in the public health infrastructure, and it's really not that different, if to my mind, than the sort of more general discussions about what should the limits on the police be and police jurisdiction and defund the police kind of movements or calls where the idea is the police should be uh, a whole lot less involved in a wide range of situations that are much better handled by trained uh, assisters, interveners, social workers, helpers, etc. And so defund the police means we need to reallocate a lot of money to these other functions so that the police aren't called on them to do it. Um, uh, Kind of different from what we're talking about here, but not unrelated.
Well, Dan, let me jump in. We have a question, which is related to the idea of defunding the police, reallocators. How do you propose that stores, et cetera, handle people who cannot wear masks? We've all seen those uh, awful videos of people screaming that they have, breathing problems and that's why they can't wear masks. Whose responsibility should that be to have that person escorted from the store? Is it the worker? Is it the management? Are we calling the police? Who's in charge of that?
No, I think that's exactly the question, or a really important question. And it's interesting if you think, well, I've had some discussions with people where they say, well, that's really not an issue about non-compliance with a public health masking mandate. That's just assault or threatening, threatening abusive, violent behavior in a public place, etc. Well, that's probably true, but if you say that's the way we should think about handling those situations, then that's the police. So in a sense, that brings, you're bringing the police in to a much greater extent than if you had somebody like at the door who was, a public health official who just said, ma'am, nope, you cannot, you cannot enter, rather than allowing, people to enter and then causing, causing a ruckus.
Right, but we can't really imagine the resources of having a public health official at every door.
Yeah.
But I think if I could jump in on that, I mean, those scenarios are rare. And I mean, there are certainly people that enter folk places and do not have a mask. And I think the notion that that calls for a law enforcement response, or that somebody had that enforcement must be had. I think sometimes we lose the big picture. There are problems, even though it's obvious, I think, that our public health system is grossly underfunded, and that there aren't the resources that we need to do what we want public health to do. We don't really need legions of public health officials, but we do need some standing up and speaking up. NASTAD endorsed a policy that encourages people to find and stay in their lanes and work collaboratively. It would be really great, and it does not take a lot of resources for state and local public health officials to play more of an active role in responding or proactively making recommendations about the rare case when somebody comes into a store. I don't think you can characterize that as assault unless it really is an actual assault going on. But there are a variety of reasons why these things happen. Some of them are related to mental health. Some of them are related to politics. Some of them are related to a variety of different things. And we also have a law enforcement community in most states that have never been trained in dealing with people with disabilities, understanding infectious disease, understanding what is and really isn't a risk, how to deal with people who are having mental health issues, which is a huge, which is probably a significant part of what law enforcement deals with. So, they're not only defunding the police, but reallocating resources and priorities in public health systems as well. Maybe we need to do a little bit less counting, a little bit more advocacy and service.
Thanks. So we have a question about resources. Where can members of a college community go to determine what policies are in place to protect an individual's privacy? So where should students look for more resources?
If people are talking about privacy of confidential medical information, there is, I believe, a national privacy project. We have the state laws governing HIV privacy by state on our website, which is HIV law and policy spelled out.org. The Disability Rights Education and Defense Fund, or DREDF, has been collecting policies related to emergency protocols and some other policies related to COVID and privacy. So there are actually quite a few places, but those are the ones that come to mind right now.
So a follow-up to that question is whether students would turn to FERPA or HIPAA.
Well, I don't know what FERPA is. Does it relate to animals? the privacy right of furry
No, I
thing?
think it's probably a student-related privacy right. So the
I think it's public schools.
Oh, okay.
You know,
Well,
privacy related to public schools, but I'm not sure whether it applies to colleges and universities or just to, you know, like high school and younger. I'm just not sure.
so the questioner has stumped the panel. We like an educated audience.
So I will just add on that. So I am not familiar with the ins and outs of FERPA. My understanding is that both apply. That does apply to higher education. But I would direct the questioner to look at both CDC resources, and I caveat CDC guidance has been somewhat tainted lately. But they put together comprehensive guidance for higher education institutions where they do cite to applicable federal law. And so I think that's one place. And then the Department of Education back in March actually came out with another set of privacy guidelines that I think better sort of distills the interplay of HIPAA and FERPA in a way that I do not know.
HIPAA, it's a lot of, one of the things that's, I mean, really, the promotion and understanding of the existence of HIPAA is something I think about from time to time and want to figure out how we can brand other laws to protect people nearly as successfully. But people tend to think it provides more protection than it does. It applies only to institutions and providers whose business includes the provision of care and maintenance of health records. So it does not, it would not apply to law enforcement. It would not apply to your neighbors or friends or things like that. So that's, but again, you know, there are resources that summarize coverage on the website, very easy to find.
So we have a question about the privacy considerations in light of stigma, right? So we all know about the stigma facing people living with HIV and the systemic racism and criminalization of public health that causes these, that creates the need for privacy. But are those concerns present in COVID? I mean, Amy touched on this a bit, you know, who has HIV, who's the perception of who's at risk for HIV, different from COVID. It's just a thing that happened to you. And so if there were no stigma, would we say that privacy isn't important?
No, absolutely not, she said. No, there are state and federal laws that protect the privacy of all one's health information. It doesn't, and again, it doesn't have to do with the fact that being sick or having cancer or having herpes is necessarily stigmatizing, even if they are. It has to do with the right to keep your personal health information private. And so, yes, yes, of course it's private. Of course it should be. And just to push back a tiny bit on the stigma thing, I think, you know, some of the identity issues connected with HIV stigma are certainly not at play now that a lot of people have been diagnosed and sick, regardless of background or SOGI or whatever. But I have personally witnessed people of apparently Asian backgrounds being screamed at and yelled at. And there's certainly, you know, references to the Chinese flu have not helped that. And it, you know, there is nothing that causes more, there are few things that touch all of us that inspire more of an irrational, sometimes hysterical response than infectious disease. To the point where Supreme Court justices have commented on it. And sometimes it's helpful, at least for me, to remind myself that, you know, we're really only in like we're not even in the first year of this. And when I think about how long it took for people to get sensible about HIV, it sure took longer than 9 months. I think It's stigma. It's also an understanding that any kind of infectious disease can be perilous to somebody who has uncertain or undocumented immigration status. It can be yet another reason for a overuse of force in a police interaction to turn in, and he threatened me to give me COVID and coughed in my face. I mean, there are all sorts of ways that people's health and disability status, certainly when it involves infectious disease, can be weaponized against them. But that's not what we don't need that fact to conclude that people have a right to the privacy of their health.
So
Yeah,
then,
I would agree with Catherine that protecting privacy of medical records and privacy of health status, it doesn't just accrue to particular conditions that might be stigmatizing, more or less stigmatizing. I do think that there's kind of an interesting question, not about having, say, if I have a COVID diagnosis, stigma attaching to that per se, but stigma attaching to my behaviors that jeopardize threaten other people, regardless of whether I have COVID, because, people can have COVID and transmit it for, I think, up to 2 weeks before they evidence any symptoms. So it's not a question of stigmatizing having COVID, but stigmatizing being reckless or selfish in one's behaviors, and whether sort of intentional manipulation of stigma is something that can actually be an effective public health strategy, or whether, on the other hand, that's really barking up the wrong tree and is a big mistake. But if you think about anti-smoking campaigns, whether or not it was intentional or an unintentional byproduct, smokers are very much stigmatized in this country compared to 30 years ago. And, I'm not sure that's been an intentional strategy to get people to stop smoking, but it's, it's nonetheless there. I'm not suggesting that for COVID, it seems like all the indications are that backfires and is not effective, but it's a question we're going to be wrestling with for some time.
So we have a question. Again, it's related to what where we've gone with this conversation about shaming people, stigmatizing people. But this question's about the public shaming of students and others who throw COVID parties. And I think what the questioner is asking, whether, we have a party in the park, we're not as careful as we should be, we're not wearing masks. Is shaming us for that conduct a way to get us to compliance? Have we seen that in the HIV context that shaming people works?
Well, that's the question.
So I think, much of what Amy was talking about, having trust and transparency, in that the listener hears that you're giving accurate information and that it's not politically driven or driven by some other non-public health motive. Maybe that's a more helpful approach. Amy?
Yeah, I mean, I would say, I mean, I think to the sort of underlying question of is shaming effective? I mean, I think generally no, we have not found that to be an effective public health strategy. And I think, I mean, a couple of things. Like, I think an evidence-based approach. And so not shaming, but an evidence-based approach of these are the levels of risk. And I've very much appreciated our scientific community friends, going to gray areas, which I know is often an uncomfortable place to be, but that is the place that we in, the HIV and hepatitis community have lived for a while of there's harm reduction, there's gradation of risk. And so, yeah, if you are outdoors, that is a less risky activity than being in close quarters indoors. And we should say that, and that's evidence-based, and we should have scientific backing for that. So I do think an evidence-based approach, and one that recognizes we're human, and humans were not meant to sit inside for 12 months not seeing anyone else. Like that's not that is not a reasonable expectation, even though that is the activity or self-protective measure that would guarantee you do not get COVID. So that is my answer to that.
Thanks. So we have a slightly contrary comment to that, but in a marketplace of ideas, you get contrary thoughts. So we have a comment. Person is stating that they think that creating a culture of safety, whether it is condom use or mask or social distancing, is important. And part of that may include shaming malfeasance.
Oh, that's interesting. I mean, and you are already characterizing it as malfeasance, which is also interesting. I think Amy, I so agree with what Amy said, and I think you can give people information, and it's a lot, in many ways, it's like HIV. There are a variety of aspects to people's health, and we tend to focus on that we tend to kind of have this laser focus on that particular disease, HIV or COVID, as if the rest of a person's life does not also affect their health and their quality of life. And I do think that there's a range of why people are doing why they do, as complicated as people themselves. But there are some folks who have made the decision that they are willing to tolerate a certain level of risk of exposure to COVID, probably more frequently among people that haven't lost anybody or haven't gotten sick themselves, that is worth the mental and emotional need of being in community. And much, in some ways, maybe not exactly because the diseases are so different, but ultimately, we have to accept the fact that people have the right to get infected with HIV. They actually have a right. They don't have the right to harm other people, but they certainly ultimately make decisions about how they're going to live their lives. And even if it were ethically and morally acceptable to police people about this, it's ultimately pointless and ineffective, so why try?
Well, I would add, though, that it can't be, certainly with COVID, based on what we know now and the measures that we have at this point to contain it or control it or keep it, from spiraling even more out of control. It's not simply a matter of my right to assume risks for myself and live the way I want to, because my conduct, the conduct of people who go to all the people who went to the motorcycle rally in Sturgis, South Dakota, and that was their choice, I think, for the most part, whether or not it was a wise choice or an informed choice. It was their choice, and they have ended up, as a result, dramatically infecting a whole lot more people, including lots of people who never went to that motorcycle rally, wouldn't want to go to that motorcycle rally, and the way that COVID spreads. There was an interesting study of the particular strain of COVID in, I think, one person at a scientific conference in Boston in February, but it was before much of anything was known. So not, casting aspersions on people at that scientific conference, but it was in February. People had the sort of interactions they do at professional conferences. And within, I think, a month or so, the study identified that specific strain of the virus in about 230 people in homeless shelters in Boston. And so,
but people that didn't have access to PPE too. So I think it's important when you talk about those statistics, whether you're talking about bikers going home and exposing other people that aren't wearing masks. I mean, I don't know. It's clear that when people wear masks, it dramatically reduces transmission, and it doesn't necessarily require that everybody wear a mask. I think I did qualify my question by you don't have a right to harm others, but there is, I guess as a practical matter, there is a limit to how we are going to enforce mask not wearing. I mean, there were arrests in New York where people were actually arrested for not wearing masks and then crowded into a holding cell. I mean, it doesn't make any practical sense whatsoever.
Yeah.
And if I could, I saw a comment from a public defender. Can I? And I wanted to underscore that the opposite. Maybe you could read it, because I did want to.
Sure. So we had a couple of more comments follow up on HIPAA. Our public defender in the audience says that the public health system has failed the incarcerated. HIPAA is regularly violated with test results shared with the court before it is even shared with the client.
I think that's absolutely right. I mean, that's in fact, I think a part of the point that I'm making, which is I think that public health officials have failed to assume the responsibility they have for protecting the health and privacy of all citizens, regardless of what side of a prison wall they live in. And I think that's a big issue. And that is not necessarily a resource question as much as a political will question. But the notion that because somebody is incarcerated, their rights don't need to be respected or HIPAA doesn't reply is, I think, a common one and wrong, legally wrong.
Okay.
I actually had a question, if we have time for it, and it was a question for Amy, actually, and it getting back to this issue of these new digital technologies that can be used for, say, contact tracing or surveillance. What's the likely uptake on those if the particular app that you were discussing is one that it's only there if I decide, of course, voluntarily to download it onto my device. It's only going to notify me that I've been in the proximity of a person with a COVID diagnosis. If I get a COVID diagnosis, do I then, is it my option to report that so that that data is available on that app, so that if I don't report it, people who are in my proximity don't get the notice because, I haven't consented to put my data into the system. And if that's the case, is it kind of really unlikely that these digital technologies are really going to amount to very much? So the the privacy concerns about them may be a little bit of a mountain out of a molehill, or am I just thinking about this wrong?
No, it's a good question. I mean, I think to the first part of what is the uptake, I don't think we know yet. There's still relatively new sort of technology and apps. And what I should have underscored, the app that Google and Apple built is only available for governmental public health authorities. So that is the only entity that can sort of customize the app and use it in their governmental public health contact tracing activities. So, at the state level, like I know, in Virginia, the state is monitoring uptake, who's using it, and who's deleting it, and what does that data look like to kind of see, is this an effective public health intervention, or is it not? I think I share your skepticism. I think on the one hand, we are all going digital, so to have something that is anonymous, that is easily accessible on my phone. Most people have some sort of smartphone, and that it does not involve a health department bureaucrat telling you about your infectious disease. Like, I actually think that there are pluses of that, but I think the downfall right now is, one, as I said, we don't have a really good testing strategy. So it's only as good as your testing strategy. If we're not testing anybody, then like you're going to be in contact with a whole bunch of people who have COVID, and you will never know, and your app will never tell you that. So that's one. And the second piece is that we are trying to roll out a public health response at like all-time low for trust and faith in public institutions. And that erosion of trust and faith is so totally and emphatically valid. And so most people, and particularly people and communities most impacted by COVID-19, have a good reason not to say, I will trust this app and the government that runs it, and I will use it in pursuit of the common good and the public health response. So I think that there are real reasons to doubt how widespread use will be, but I think it's an interesting thing to watch, because I think it does get around some of the stigma issues, surrounding traditional contact tracing.
Thanks. I want to quickly just catch up on these final questions before we sign off. We've gotten some more resources on HIPAA, referrals to the Office of Civil Rights website for their FAQs. We have a detailed question about the workplace and employers' rights. And when we were planning this panel, we recognized that the questions of what employees' rights are in the workplace was so involved that we didn't want to combine the two. So keep an eye out. There'll be another panel talking about employee rights in COVID. And then finally, questions about, well, do we need privacy, considering that, an HIV, you can establish your own risk, but you don't have that same ability in public health. Are we putting people at risk by being too concerned about privacy measures? Is that gonna backfire? Shouldn't keeping people safe be more important than privacy? And I think that what we've had after this spirited conversation for an hour and a half is a lot of good questions, a lot of good cautions and concerns about how we can actually do it both. We can protect the individual's privacy. We can protect the public health. We can keep things safe. We have to look at some of these lessons, look at some of these suggestions. I mean, we know that an absolute position is not going to save anyone. So let's think about where we are. Maybe we meet back in 6 months and we look at whether some of these suggestions have been implemented and how that will work out. That would be sometime in the new year, post-national election. So we can see where we are then. But for now, I want to thank you all for joining us for this free webinar. I want to thank our panelists for taking time out of their schedule, providing us with some food for thought. The section of Civil Rights and Social Justice provides free webinars and resources for legal professionals and advocates nationwide. We hope that this conversation and other conversations like this are helpful in your work. And again, here's the plug. If you can, please consider joining and becoming an active in the ABA. You may do so at ambar.org/CRSJ. You can find information on other free programs on the CRSJ webpage. Best of luck to you in your work. And for now, take care and stay safe.
Thanks, Rhonda. Thanks, everybody.
Thank you.
Thank you.
Well.